Is Dr. Adam Kaplin, who works, a psychiatrist who works with the Johns Hopkins TM Center, a member of that group of physicians who do all this wonderful work. And he's also on the TMA Medical Advisory Board. The work that Adam is doing in cognitive dysfunction and depression is literally groundbreaking in our community, and the significance of this work really can't be overstated. The Transverse Myelitis Association did a survey and got 815 responses back. There was an open-ended question which asked people to identify their symptoms. That means we didn't prompt them with muscle weakness, paralysis, bladder, bowel, so forth. It was an open-ended question. And what we got back from that was that there is some guy in Alaska with sexual dysfunction and some guy in Utah who's depressed. And we know that that just is not the way things are. This is a subject that people have a difficult time talking about, recognizing in themselves. So the work that Adam is doing to put this in front of all of us to deal with and explain is just so critically important, and we're so glad that he's doing this work.
It's the pressure's on, I think, now that I had such a wonderful introduction from Sandy. Thank you so much. I'm going to start with my daughter's favorite joke. A man walks into the office with a duck on his head. The doctor comes out and greets them in the waiting room and says, "How can I help you?" And the duck says, "Can you get this man off my butt?" Now, this is her favorite joke, but I bring it up because I find that what often happens in the case of depression, as well as cognitive impairment, by the way, it can be very subtle, that patients often think about what's going on with respect to a set of symptoms that they're experiencing, and my job is to sort of put it in a new light, sort of change the way they think about things, because a lot of times there is an underlying depression. Sometimes it's just being demoralized, and sometimes it's a very difficult time. Because it's not loud enough? Oh, can you hear me in the back? Yes, okay. No, I'm just so used to Chitra telling me to keep my voice down, which is sort of her perpetual reminder, but I tend to be very loud to begin with. By the way, what I should tell you is this is part one of two talks that I have the privilege of giving. They're both right before lunch. Tomorrow, say again? Tomorrow I'm going to be talking also just before lunch, so I'm what's in the way of you guys eating. I'll try not to bring anything up that sounds savory or worth thinking about related to food. But today I'm going to be talking about sort of the experience and the clinical side of depression and related concerns. And tomorrow I'm going to be talking about the biology and some of the research. So again, I love Kathy's work. You may see me walking with a limp, not because I want to get on that neat little computer-generated thing. I actually sprained my ankle, but that was sort of her research, and I'll be presenting more about the research that we're doing tomorrow. Okay, this is a study that actually came out of San Francisco. And it's an interesting study. This is somewhat like the study that Sandy was making reference to, where they made phone calls in this case, but to people in the community who had multiple sclerosis. And they made phone calls and said, "How's it going? What's going on with your life?" And what was interesting is, and I'm just sort of giving you the take-home of a rather lengthy paper, but the interesting thing is that they were able to cluster the people's responses to how are things going, what's going on with you in your life, and they could cluster them into three general areas. One was that much of what was said related to people who are affected with multiple sclerosis, referring to how it had deteriorated their relationships with their friends who no longer wanted to spend some time maybe walking more slowly, or that it had put strains on their relationships. That was 1 in 5 people. They got 30% of people responded that they were demoralized in some way. And we'll talk about what demoralization is. I should tell you that depression is very common, and certainly a significant portion of this 30% were people who were depressed. But again, the take-home message from this slide is that 60%, not, again, 3 times as many as complained about troubles with relationships. Twice as many people as said they were demoralized, said that in some way they had what they called benefit finding in this study, by which they meant that somehow the experience of having MS had enriched their lives. And when you sort of first hear that, you think, come on, I mean, who are you kidding? But let me show you in what ways they actually described these, the kind of responses they got. My friends and family have become more helpful. 77% said that. I am closer to my family, closer to my significant other. I keep better in touch with my family. And again, I've had the privilege of working with a number of people who now had to spend more time at home with their kids and got to know their kids in a way that they never did before. I've learned to be more compassionate, to be more respectful of others. Communicate better. I appreciate the importance of being independent. And I'm told all the time by my patients that walking is something wasted on the ambulatory, that it's just the lack of appreciation people have for being able to get up and move around is you don't think about it much unless it's something that's impaired. By the way, most of the literature, most of the studies that have been done out there have been done on MS, but as I'm going to show you, everything I'm talking about with regards to the studies on MS really do pertain to the whole spectrum of autoimmune conditions, including transverse myelitis and DeVix and the like. So this is a quote from George Eliot: "There is no despair so absolute as that which comes with the first moments of our first great sorrow, when we have not yet known what it is to have suffered and be healed, to have despaired and recovered hope." And again, hopefully, lightning has not struck lightning bolts the size of the autoimmune illness has not struck twice with respect to medical conditions, so that often when people are confronted with these illnesses, initially anyway, for the vast majority of people, this is a tremendous transition. You don't know what it's like, what's going to happen, that sort of incomprehensible sense of what is the future going to bring is greatly difficult and obviously a struggle for everybody to cope with. And there is a condition that was actually described and worked on originally at Johns Hopkins by Jerome Frank, who passed away just a few years ago. But he described this state of demoralization, and he basically operationalized something that we all know, we all have experience with, but described this as subjectively as people, when they have their thoughts, feelings, and beliefs, are that they failed to meet the expectations. Usually it's of themselves, but also they feel they're failing to meet other people's expectations. They feel overmastered, by which they not only can't cope with the problem in front of them, but simultaneously they feel they can't cope with it, but they can't change the situation or get out of that predicament. And that sense of being trapped often leads to a sense of being demoralized. And finally, there's this sense of isolation. I feel awful. No one else understands it. I'm not going to burden anybody else with how I feel. And therefore, I'm the only one who feels like this, because you don't find out that many other people have the same feelings. Now, we all have coping strategies that we use to deal with what life throws our way. And we all have a point. I mean, regardless of who it is, we all have a point beyond which we no longer can cope on our own and become demoralized. So how do you treat demoralization? And again, this is something I try to teach the residents at Johns Hopkins and the like about, but this applies as much to what I try to teach my patients as well and their family members, which is often the sense of demoralization is because it's the end result of a building number of hurdles that feel insurmountable. And what often the most important thing to do is just to try to break it down into smaller problems that you can work on. Because trying to deal with the whole thing, okay, now I've got transverse myelitis. What does that mean? How am I going to learn about it? What am I going to do? I've got, bowel bladder problems. And there's a host of things to worry about. So again, sometimes it is, for example, I've had patients say, well, I can't. I say, well, what's the worst part of what's going on? Well, I lost my independence. For example, what? I can't go shopping anymore and get the groceries. Well, why not? Oh, because it's such hustle and bustle, and I have to, sort of sit there using my walker to get around. I say, well, could you use the cart in the store? Well, yeah, I could, but people are rushing by me. Okay, what if you went at off hours? Well, I guess I could go at off hours and try to get right. So why don't you try that? And if that person goes out and realizes they can go at off hours and not have the hustle and bustle and go shopping, that is an achievement. And that achievement can be the start of many achievements. The journey of 1,000 miles begins with a single step. And just being able to break it down. And again, the number of times I have patients come in and say, I think I'm demented, I can't, remember anything, and by which they mean that they used to keep all their numbers in their head. I can't keep my own phone number in my head on some days, and if it wasn't for this, I'd be in real trouble. So I just have to explain, you used to be able to do this. Now you have to be mortal like the rest of us, perhaps, and have to write the numbers down. So another thing that's critical, and again, you could talk to Sandy about this, the importance of support groups, but also everybody here is getting educated. And this is a critical component of trying to prevent, head off, and also overcome demoralization. Because, it's what you don't know that can scare you the most. Once you begin to understand these things, you can begin to get some control over them. And a lot of times it's just, you need a reminder that it's okay to be merely human, and having a chance to sit and talk to someone about that can be helpful. So this is one of my favorite quotes. If you can't be normal, be spectacular. And this is a quote that Cody Unser actually made. And although, and I hope you know I mean this affectionately, although Cody is a brat, she is a spectacular person, and she has overcome tremendous hurdles. And I think what Cody sort of is talking about here is that, this is the peace she's made with her illness. And I think that this is the end result of someone who has been, through the other side of being demoralized onto this side. I mean, I'm reading a lot in Cody, but I think that Cody embodies for me sort of the spirit of what it should be when you get to the other side. Now, the other issue that I think is critical and critically under-focused and underrepresented is the issue about the caregivers, which is probably half of the people in the room. So again, this is poorly studied, but the spouses, the children, I've met people who are here because they have a loved one at home who can't travel here or wouldn't come here, but they're here to try to help. And the important thing to know is that it's bad to have any one of these diseases that we've talked about, but to be sort of up a creek and to suddenly lose any hope or semblance of having a paddle, you're in really big trouble. So what I always do is I try to make sure that my patients have a firm grip on the paddle and that the paddle's doing okay, by which I mean I always make sure that I spend time, probably sometimes a third of the time, sometimes even half the time, talking to the caregiver. And again, I won't ask for a show of hands. I always get the same answer, which is when I ask people, how many of you who are caregivers have ever, when you went to see your doctor, had the doctor say, okay, great, and take you into a separate room and spend time just touching base with you and seeing how it's going? No one ever raises their hand. This just isn't done in general, and it's something that I always do because, again, the health of my patients is critically dependent on the status of the caregivers. It is worth letting you know that although in a number of studies, caregivers always say that there are very positive things about being a caregiver, but there also are negative things about being a caregiver, and I will tell you, patients generally undercall the level of difficulty that their caregivers are having. In other words, the patients tend to, for reasons that are obvious, that's where the focus is on the disease that they're coping with, are focused on their disease and tend to not focus, just like the doctors don't focus on the caregivers. But again, the point I just want to make is that the wellness of the caregiver is often neglected, and people say, well, of course I don't go out, I don't have my friends any longer because I'm so busy taking care of my loved one, my child, my spouse, and the like. And of course I don't go out and see movies anymore because, I can't just, we can't just go out together, and it's, difficult to go out and do these things. But I think if there's one take-home point is that it's not, it's not just that it's your spouse, they have the disease in their body, but that disease has affected you. Okay, it's affected your whole family, and you all are sort of in there together, in the life raft together, and everybody, if you're going to survive, everybody has to do well. So the take-home message is that it's absolutely critically important this is, and please let Alan Greenspan accept the things he cannot change, give him the courage to change the things he can, and the wisdom to know the difference. Obviously, it's important to know when and where to intervene and not get sort of stuck in a strategy that doesn't work. I had doctor one time whose wife was a nurse, and the doctor had, the worst patients in the world, without any question, are doctors, and he had transverse myelitis. It felt he was burdening his wife. She wanted to help. He didn't want to let her help. So half the problem was just him saying, okay, I'll let her help, so that they could sort of work together. That was a failed strategy. I don't want to burden her, and then she just felt really hurt. So try not to get stuck in failed strategies. But the other thing that's critically important is that the caregiver needs to realize that taking care of themselves, and in the studies, caregivers' health are worse. They tend to die younger because they don't go to their own doctors regularly, and the like. That taking care of themselves is not taking time away from their loved ones. It is absolutely essential that they do so, that they take care of themselves in order to be available to their loved ones. And again, what this is to remind me of is that, when you get on the airplane and the flight attendant comes out and explains the seatbelt to those people who shouldn't be given sharp objects during the flight, how to get in and out of a seatbelt. Then they explain to the people there that if during the course of this flight, the cabin loses pressure and the oxygen masks drop down, parents traveling with children should put the masks on who first? Yeah, and the caregivers who are in trouble are always the people who, when I ask this, they always say, on the children, of course, okay? And what I explain to them is that when that oxygen gets sucked out of that airplane, you have about 20 seconds before everybody loses consciousness. If you're there fighting to get that mask on that kid and then you don't succeed in 20 seconds, the kid isn't going to make it and you're not going to make it. If you put it on yourself first, you can sort of half make an effort to put it on the screaming child. When they pass out, great, you just put it right on. Everybody does well, okay? So what after explaining this to the loved ones of my patients, that then when they come back, I ask them one question: are you getting enough oxygen? By which I mean, are you making sure that you're going out, spending some time devoted to getting your engines recharged, even if it's every weekend going out to a movie with friends or what have you. So again, to the patients in the audience, send your loved ones out. Make sure they're getting enough oxygen. Make sure that they have a chance to recharge their engines. When they come back, they'll be that much better off to work with you. Okay, so now again, what is MDD? It's not man in a deep depression. It's major depressive disorder, but sort of to give you an idea about depression, which is now we're switching from demoralization to depression, I think it's no better exemplified than 2 years ago at this conference. I was sitting in the clinical side, and someone called me over, and she didn't know that I was the neuropsychiatrist at the conference. She just called me over, and she said, and she'd been through a day of lectures, and she said, when is someone going to get up and explain and sort of talk about how having transverse myelitis, she had transverse myelitis, is like being dead while you're alive? And she said, when are we going to get to that? And I said, I'll get to that. We'll talk about that. Just hang on. So again, depression, we've known about depression since Hippocrates. Hippocrates called it melancholia, black bile is what it translates to directly. But this is something that, as far back as the Greeks, was considered one of a number of medical conditions. They didn't differentiate between melancholia and any of the other ailments people had. It was yet another medical illness that needed to be diagnosed and treated. So they sort of had very little stigma back in that time, nothing like what's arisen today. So what's depression? And again, what I hope to do is convince you that what you think you know about depression is actually wrong. And that's true for everybody here, except those people who have had depression and had it treated. Because if you've not had depression and not had it treated, you won't understand why one of my patients, for instance, told me just the other day, look, Dr. Kaplin, I'm starting to get depressed again, and I've had open heart surgery, and I've been depressed, and I'd rather have another open heart surgery than go through that again. And if that doesn't register with you, then you probably have not had depression and not had it treated successfully. So again, just to dispel some of the myths, first of all, the brain does a number of things. It's not hard for people to understand that the brain would control nerves that wire the gluteus, minimus, maximus. Kathy will have to educate me about all of the various gluteus muscles and the like. That's not hard for people to understand. It's not hard for people to understand that you could have troubles with these illnesses that could affect your brain and lead to trouble with memory and concentration. The fact that there is a part of the brain that regulates our moods is difficult for people to understand. But again, there is a mood thermostat, and when it gets stuck, people get depressed. Just like if the thermostat in this room got stuck on low, it would get colder and colder and colder, and nothing would lift it up and make it hotter. So again, it's that unresponsiveness that is one of the hallmarks of it. But we know that there's a biology to this depression. We can actually measure changes in the brain, which I'll talk about mostly tomorrow. In the brain of people who are depressed, they actually have regions of their brains that shrink 20% over the course of, if they're not treated, over the course. So it turns out that depression is toxic to your brain, that we can measure changes in people's rapid eye movement, sleep, that there are a number of tests, cortisol suppression tests and the like, that there's a real biology, that there is a thermostat. And one of the best examples of this, by the way, is they're doing now deep brain stimulation to treat patients with Parkinson's disease. There's a very interesting case where they accidentally placed the probe in a region that turned out to be wired to this mood thermostat, and every time they turned on the stimulus, this woman would start crying and have this sense of overwhelming doom that would sort of possess her, and she'd say, turn it off, and then they turn it off and suddenly she'd feel fine again. That they had put that electrode right into that mood thermostat, turned it on, and she got all of the symptoms of depression that we'll talk about. Again, but the one thing I just want to make sure people understand is that Lou Gehrig's disease, ALS, arguably the worst disease you can be diagnosed with. From diagnosis to death is normally about 6 months to a couple of years at most in most cases, and you die because you become completely paralyzed on a ventilator and you get pneumonia. Terrible disease, right? And I will tell you that this is a disease that affects the nerves that go and wire the muscles, and they stop working, and so you can't control the muscles. Terrible disease, but it doesn't affect the brain. It affects the wires that go out to the muscles, the motor neurons. It's a motor neuron disease. And the rate of depression, clinical depression in those patients, is rare. They don't have depression at any greater rate than anybody else in the medical setting, than people coming in with colds or the flu or what have you. It's uncommon, and when they've studied it, right up until their death, they don't tend to get depressed. Doesn't mean that they don't get demoralized. It doesn't mean that they aren't having a hard time dealing with the disease, but they don't get the constellation of symptoms that we'll discuss in a minute that we call clinical depression. They may say, this is a terrible situation I'm in, this is awful, but they don't tend to get the kind of situation where they say, I'm awful and I deserve this, and nothing is, I don't even want to hang in there for 6 more months because this is just awful. And we'll talk about that. Oh, one of the things that is always interesting to me is that many people with these autoimmune diseases, multiple sclerosis and transverse myelitis, end up telling me these stories that it took a long time to convince the physician that something was wrong, which is where my job gets much harder because the physicians tell them that they need to go see who when they can't figure out what's wrong. A shrink, yes. And as one of my patients put it, who actually saw me for his transverse myelitis, but also saw a urologist, and he'd get up in the morning and he'd say, honey, I'm going to see the nut doctor. And she'd say, is that the psychiatrist or the urologist who you're going to see? Again, the point is that it often takes a while, and when those symptoms of weakness, numbness, dizziness, and what have you are dismissed as just, this is all in your mind, and it takes a while to convince the doctors, no, there's something wrong, you need to get an MRI, then you find out what it is. What I ironically have to do is say, look, these symptoms that you have, these depressant symptoms, these are not just, all in your mind. They're in your body. They're in your brain. This is not a weakness. This is not something you're doing. This is part of the disease, part of your multiple sclerosis, part of your TM. And, just like you have weakness, just like you have urinary problems, this is now one of the more common symptoms you can get. Again, it's not a character flaw. Many conditions will cause depression. It's worth noting that transverse myelitis and multiple sclerosis are the record holders. Higher rate of depression, clinical depression in TM and multiple sclerosis than in any other conditions, whether it's Parkinson's, Lou Gehrig's, as I talked about, ALS, Huntington's, Alzheimer's disease, MS, and transverse myelitis, highest rates of depression ever described. And that's because these conditions attack the brain in a specific way, and that attack leads to this. Again, just to sort of, I'm going to go through these quickly. This is just to convince you that this is important, the depression. Former Surgeon General Satcher said few Americans know that far more Americans die from suicide than from homicide. This is a major public health issue. We know how violent the world is we live in, but it's really mostly violent because of depression, and you're much more likely to kill yourself than you are to be killed by anybody else. It's the single best predictor of whether your heart will stop beating after you've had a heart attack in 12 months, because it turns out depression is bad for the heart as well, probably because it's bad for the neurons that control the autonomic nervous system that controls the heart. It's also the second leading cause of chronic disability. This is, I can't understand a word you're saying, Roger. Have you got a gun in your mouth? And you don't want to be this guy. So again, but the point is that when you compare hypertension, diabetes, heart disease, arthritis, and lung disease to depression, black means the medical disease caused more disabilities when measured in these 5 different ways. Gray means the depression caused more disability, and white means that they broke even. And you can see, just looking at this chart, that second only to heart disease, depression is the second leading cause of chronic disability. So if it doesn't kill you, hopefully it won't, but if it doesn't, it certainly is the cause of major disability. And again, what often happens to me is that there's sort of a dismissal of the diagnosis. Other clinicians tell me, look, they're not depressed, they're just stressed. You'd be stressed too if you had their condition. Don't know when the next attack's gonna come, don't know if I'm gonna get better from these set of symptoms. And then when I sort of persuade them they're depressed, so they say, okay, sure they're depressed, but let them, they'll just get over it, right? Just get over it. And the problem is that stress doesn't prevent you from getting depressed. In fact, stress is a risk factor to getting depressed. So just because you're stressed doesn't mean you won't get depressed. It means, in fact, you're more likely to get depressed. But the other thing that's worth noting is that, for instance, in transverse myelitis and multiple sclerosis, there's no correlation with clinical depression and disability. It's not, gee, you'd be depressed too if you were in a wheelchair and I'm walking around, so I'm not depressed. It doesn't correlate with that. It correlates, as I'll show you in a minute, with the number of attacks or just the severity of the attacks on the nervous system of the immune system. And so what is depression? It's not normal sadness. Sadness is, if you're not sad at some point during the course of your life, you're not paying attention to what's going on around you. So that's depression with a small d. It's normally sort of responsive to the environment. Good news, someone leaves you and your wife leaves you, you're terribly upset and concerned. They come back, you say, honey, I knew you'd come back. I knew we'd be able to work it out. The depressed patients I have say, you don't really love me. You just came back because you're guilty, okay? So it's important to realize it's that lack of responsiveness that's critical. And again, the sadness issue becomes very complicated. So for my clinical colleagues, what I try to tell them is just like cough can be an indicator of pneumonia and sadness can be an indicator of depression, it's just one symptom. So not every cough is the result of pneumonia. And sometimes you can get pneumonia without a cough. You can get depression without sadness, particularly in kids. Instead of sadness, you see irritability. Instead of that sort of normal sadness. So you got to consider the company the cough keeps. If it's cough, and I won't get detailed into what it's like because we're going to have lunch soon, but basically if it's cough with a set of symptoms, we call that pneumonia. This is the set of symptoms that we call depression. And we sort of remember them with the acronym SIG-EM CAPS, which means nothing to people who aren't into medicine. That people always come up and say, why SIG-EM CAPS means nothing? But CAPS is short in medicalese for caplet. SIG is how you take a medicine, and E&M is emotions and moods. So this actually means something if you write prescriptions. But anyway, it gives us this set of symptoms. You need to have at least decreased interest or decreased mood, and then 5 of these 9 symptoms. Trouble with sleep, either increased or decreased. Loss of pleasure, your get up and go has gotten up and gone. Feelings of guilt or worthlessness, low energy or fatigue, low mood, concentration troubles, increased weight. Chocolate for women is what they tend to tell me does it when they're depressed, that carbo craving, that comfort eating, or loss of weight. And lots of people are sent to me, they were diagnosed with having cancer, but they couldn't find the cancer. They were just very, very depressed. Psychomotor retardation, which means you can look at the person and know something's wrong, and then thoughts of death. More symptoms you have, the more likely you are to respond to treatment. And this says, after many years of marital bliss, tension enters the Kent household, and Lois Lane's embroidering stupid on the cape. And what I will tell you is if you're not sure if you're depressed, you can ask your spouse. And they will tell you whether or not you're depressed. It's more often than not, it's the spouse that sends people in to see me. And the reason for that is, number one, when you're depressed, you don't want anybody to know and you don't want to burden anybody. But the other thing to know, by the way, and this is important to understand for the spouses or parents out there, is that it's not just that they're picking on you, although you are easy pickings because you're around late at night when no one else is there to pick on. But it's also more important than that, which is when we're out in public, we all put on our best face, okay? We put our best foot forward and we try to, mobilize what resources we have. And then that takes a tremendous amount more energy than you know if you've never been depressed to do that while you're depressed. To make yourself look fine and happy when you're really depressed takes an immense amount of concentration and effort. And then when you go home, you just have to stop. It's like you've been running a mile, a 4-minute mile all day. You get home, you have to just relax. And when you relax, you let that guard down and you're no longer that happy-go-lucky guy, that the best face you've been putting forward. You actually are what you are, which is depressed. So the family often gets the brunt of it. And they see that for that reason. Now again, just this is Charcot. He's actually the person who first described multiple sclerosis. And I just find it interesting that the very first patient that he ever described, he's the father of multiple sclerosis, first patient he ever described back in the 19th century was this woman, Mademoiselle V, who experienced periods of serious depression accompanied by paranoia that made her think he was trying to poison her. And in fact, it was so severe, her depression, that she stopped eating and had to have a stomach pump put in to keep her alive. That's the very first patient who was ever clinically described to have multiple sclerosis. So it's not like we haven't known about depression associated with these conditions right back to the very first patient described, but ironically, it wasn't until the last 10 or 15 years that anybody ever studied this. So again, as I told you, highest rate of depression following the diagnosis with MS or transverse myelitis, for example, 50% of patients will get clinically depressed at some point during the course of their life. It doesn't have to be immediately, and it doesn't have to be down the road. It can occur anytime. That is three times the rate of the general population, and in cross-section at any given time, about 1 in 4 patients with these illnesses are in a clinical depression. Now, that's in the general medical setting. That doesn't mean everybody who's coming to this conference, 1 in 4 people are depressed. It doesn't mean it's higher or lower. That's just, if you look at all MS patients in a clinic, those are the statistics you find. So again, I'm not going to go into the evidence for this, but let me just tell you, the evidence does suggest that depression is caused by the inflammation. It's not a weakness. It's caused by it's just like the other symptoms that you get, like the tingling when you put your chin on your chest for those people who get Lhermitte's sign. It's just one of the set of symptoms that happens when your brain is under attack. It doesn't correlate with physical disability, which is what it would have to do if it's just, gee, you'd be depressed too if you had this terrible thing. And it also tends to occur during periods of time of inflammation, and we'll talk about the biology of it tomorrow. The important thing to know is that depression correlates most highly in all of the studies that have been done. It's the main factor in determining quality of life. So when you ask patients how they're doing, it has a greater impact than whether they're in their level of physical disability, their fatigue, their cognitive impairment, or anything else. If a patient is depressed, all bets are off for everything else. It's the worst. It's the pits. And remember, patients will come from all over the world to come to Hopkins for some chemotherapy that may add 6 months to their life. It's an experimental chemotherapy. But my patients who are severely depressed, they would rather sit at home and even think nothing's going to help them and attempt suicide than just come in and get treated. Just come in for their first appointment. So it's the primary determinant there. It also has a significant effect on function. It correlates with loss of social support, feeling you get isolated when you're depressed because you tend to not go out. It's a major cause of people stopping working. It's a major cause of people not being able to participate in their rehabilitation and their care. It also worsens cognition. So I'd be happy to talk to people about the cognitive impairment in more detail later, and perhaps I'll spend more time on it tomorrow, but it's just important to know that depression is a cause of cognitive impairment. MS causes cognitive impairment in 50% of patients with MS and transverse myelitis as well. We've found high rates of cognitive impairment. But the important thing to know is that if you've got one cause, it doesn't help to have another cause there too. And a lot of times patients come in and I tell them, look, I don't know if it's the depression or the MS. I understand you're having trouble with your concentration. It turns out to be 90% depression. You treat it and their cognition gets dramatically better. Sometimes it's 90% the TM, but you don't know unless you get the depression out of the way and treat it. Also, with respect to fatigue, people always want to say, look, I'm fatigued because of the MS. There's a particular type of fatigue where people who describe that they're always fatigued and it interferes with all the activities. So autoimmune fatigue tends to hit you at about 2 or 3 o'clock in the afternoon. You wake up feeling much better, and as the day goes on, you get more and more fatigued, and then by 2 or 3 o'clock, you hit the wall, and you feel you can't take another step. That's classic. Not everybody has classic autoimmune fatigue. Depression, on the other hand, often has worse in the morning, better at night. It's reverse. So if you have somebody who wakes up in the morning, feels awful, can't get out of bed, this is what I hear so often. Do you think my wife's depressed? Well, what makes you say that? She hasn't gotten out of bed in a month. Okay, maybe that's a reasonable question to ask at that point. People who say they just can't get out of bed in the morning, okay? But the evenings, they're up and bouncing around. That's not MS fatigue. So again, and this is the really frightening part, which is that 30% lifetime incidence in people with MS of thoughts of wanting to kill yourself. 6 to 12% of patients with MS will attempt a suicide. And it is the third leading cause of death in multiple sclerosis. I'm sad to say that in transverse myelitis, in our clinic, of the 750 patients that Doug has seen at Johns Hopkins and been involved in their care, 60% of the deaths, the number one cause of death in TM, has been suicide. And this is it's like, smoking, as they say. This is the most preventable cause of death in transverse myelitis, bar none. So it's severe, and this just shows behind pneumonia and cancer, suicide, the third leading cause of death, but pneumonia and cancer tends to occur in the elderly. So if someone's going to die relatively young and with many years left in front of themselves, that's often that. So transverse myelitis, again, when we looked at transverse myelitis, everybody thought it was just a spinal cord injury, had nothing to do with the brain. Doug was trying to convince me to come over and work in the TM clinic. I said, they're just demoralized. It's not depression. He said, come look, let's study it. And when we studied it, here, this shows you severe depression is in the blue, dark blue, mild depression is in the light blue. This is MS compared to the general population. And transverse myelitis had at least equal, if not greater, rates of depression than MS, which was the record holder. And we said, maybe there is brain involvement in transverse myelitis, and I'll just have to ask you to take my word for it. The purple pattern here, purple is bad. It means the higher the purple, the worse you scored on these tests of memory and concentration. And we saw the exact same pattern in patients with transverse myelitis. It's not, they were just demoralized too. They also had the same memory problems that you see in MS. And of course they did, because now we understand that the immune system is attacking the brain. Even though you don't see that, the lesions on the MRI, that immune system that has gotten into the brain and spinal fluid is pumping out all these chemicals, and those chemical messengers cause the depression. It doesn't correlate with motor disability, bladder disability, or sexual function. There was a mild correlation that accounted for 10% of the variability in pain. The worse your pain, the worse your depression. Now, that may be because people who are depressed have worse pain, or maybe the people who have worse pain have worse depression, but the two go hand in hand, at least compared. Now, again, someone asked the question earlier about steroids of Ben, and Ben made a very good point, which is, it's not going to improve the ultimate long-term outcome, and whether you should get steroids or not is a risk-benefit analysis, which is, if you can't see and you can't drive, you should get steroids. And it's definitely something you should consider and look into. However, everything that has benefit, if it's something that really can help, it can also have side effects and risks. And it's worth saying that when we looked at the things that correlated with depression in patients with transverse myelitis, those people who had received IV steroids were 70% more likely to have depression at some point. Now, granted, maybe those were the people who were depressed when they came into their doctors. They looked really bad, so they got steroids. Can't prove this. This wasn't a prospective trial. But it's just worth mentioning that we know from other studies steroids can increase your chances of getting depressed. So if you already know steroids make you depressed, then tell your doctor this is the risk. May have great benefits and you should do it, but it may have risks. And again, this just shows you the rate of suicide in depression, the rate of suicide in MS, and this is the rate of suicide that we have in transverse myelitis. So I'm going to summarize briefly now, just to finish up, that we know that the worse your chronic stress, and presumably there, since depression is one of the worst chronic stresses, the worse your chronic stress, the greater number of lesions that patients have on their MRI. So it turns out acute stress doesn't cause, something, you get into a car accident. I'm not recommending doing that, but that's not the kind of stress that tends to increase your chances of having worsening of your MS or transverse myelitis. But chronic stress, like depression causes, is correlated with this. What patients always happens when they get sent to me is patients have been through the process of trying to find somebody who will figure out what the diagnosis is, just like with the MS and TM. And what's happened is because they weren't sleeping, they were given benzodiazepines like Valium to help with the sleep, but because they also were fatigued, they're now given Provigil, and the Provigil worsens their sleep, so they have to have higher benzodiazepines. And in addition to having the benzodiazepines, they had concentration problems, partly from the MS, maybe partly from the depression. And now the benzodiazepines, it's like being drunk. If you take enough Valium, you will have trouble with your concentration as well. So it's just worth stating that one of the things I often do is try to detox people from what their doctors have done by not making the diagnosis of depression. If you treat this symptomatically, symptom by symptom, you'll make people worse. And if, on the other hand, you treat the depression, what's interesting is this study suggests you'll actually make the MS better. And in this study, they studied the aggressiveness of patients with MS, how aggressive their immune system was when they were depressed. Turns out patients who had depression, their immune system, as measured in the laboratory, was twice as active and aggravated as the patients who weren't depressed. And then when they treated them with either antidepressants or, in this case, psychotherapy, only those patients whose depression improved, their immune system quieted back down, leading these study individuals to conclude treatment of depression may be a novel disease-modifying strategy to get people well. So you should get treated not just for yourself, not just because your family deserves you to get treated if you're depressed, but you should get treated because it may very well impact significantly on the course of your disease. Of course, your daddy loves you. He's on Prozac. He loves everybody. So the good news is that actually depression is the most treatable syndrome associated with multiple sclerosis. And my neurology colleagues sometimes tell me how jealous they are that a patient come to me who's not working, been in bed for a month, having a horrible time of it. Family doesn't know where they went. This is not the person I married. This is not the mom and dad I remember. They've changed dramatically. You treat the depression in a month, they're back at work, they're doing great. Okay? You can't do that usually with the kinds of things that the other insults. And I'm just going to let you know it's treatable. I'm going to skip that. Again, no pill can deal with the problem of wanting to take a pill. Likewise, no amount of psychotherapy alone can prevent my manias and depressions. I need both. This is one of my mentors, Kay Redfield Jameson, who incidentally, the way she dealt with having her terrible illness was she went to her chairman. She said, I know you're going to fire me. I've got bipolar disorder. I had a crazy psychotic mania. And what his advice to her was not that I'm going to fire you. He said to her three things. He said, learn from it, write from it, teach from it. Okay? She is a better doctor today because she's got bipolar disorder than she was without it. And again, you can utilize these things and turn them into benefits often. So just to conclude, depression is a two-way street. MS causes depression. Depression and stress worsens MS. Treating the depression improves the MS. I showed you some of the data for that. Treating the MS improves depression. We don't have studies for that, but again, I'd like to do those studies, but that would sort of be consistent with the rest. Certainly something I believe clinically. So it can have lethal consequences, certainly devastating consequences to the quality of life, but the most important thing is it's treatable. This is Paula Lazarus, also one of my other mentors, who here she's graduating, walked across the stage. Here she's having the child she was told she could never have. Here's the hunk of a baseball playing man that she married, who then decided to become a physical therapist through his interactions with her. And she said, I have to face many challenges in my life. I have had to endure numerous physical and emotional hardships. But my life is good because I will have it no other way. My life is beautiful because I choose to see life this way. We cannot control all of what happens to our bodies, and we cannot control what goes on in the world around us, but we do control how we think and feel about ourselves and our families and the world we live in. The last time I actually had to introduce this person, I burst into tears, which I'm not going to do today, for those of you who are here. But let me just tell you that Paula, again, is the best example, I think, of how you can overcome the demoralizing effects of these illnesses. However, if you're depressed, you can't be Paula and be depressed, okay? That only makes you worse to hear that if you're depressed, because you think, I'm a wretch, and how did she do all of that, and I can't do that. The problem is Paula's fabulous, and for those of you who are demoralized, talk to Paula. Those of you who are depressed, talk to me, because poor Paula can't help you. And but I will tell you that you can become Paula if you get the depression out of the way. The deeper sorrow carves into you, the more you can hold, joy you can hold, and the one law that changes that does not change is that everything changes, and the hardship I was facing today is only a breath away from the pleasures I would have tomorrow, and those pleasures would be all the richer because of the memories of this that I was enduring. That's what happens to you if you get your depression out of the way. Don't settle for this is the best my life can be unless you've really excluded all of the possibilities, and depression is the one possibility that gets missed all the time. So these are the people who have taught me, Doug has invited me into this line of work and the like, and TMA and all of the people on this slide have helped greatly for me to be able to give this talk to you today. Thanks very much. I'm done, so we can maybe take a question and then head to lunch. Thanks very much.